Then I open this academic ceremony in which Sriganesh Kamath will defend the academic thesis called Assessment and Management of Perioperative Pain in Neurosurgical Patients. Before we start, I'd like to welcome especially the people who are online. We can't see them, but I hope there are many. And I would also like to introduce the supervisory team, because normally they are not mentioned, and then there are persons and nobody knows who they are. The first supervisor is Professor Steinbusch, and he is a professor of cellular and translational neuroscience at our university. There's also a supervisor who is joining us online, and that's Professor Satya Prabha. She's a professor of neurophysiology at NIMHANS in Bengaluru in India. And of course, we also have here as a guest, we are very honored that you came all the way, Professor Rao, and he's a senior lecturer at the Faculty of Medicine, also at NIMHANS in Bengaluru. Now, having done this, I'll introduce myself. My name is Nanne de Vries. I'm an emeritus professor of health promotion, which is not really anesthesiology, but still. And I'm honored to chair this session as a replacement of the director. So, having said this, I would like to ask you to give a small summary of your work.
Thank you, Pro-Rector. A very good morning to all. Highly esteemed members of the degree committee, members of the Corona, dear friends and family. Next 15 minutes, I will be presenting a summary of my thesis titled Assessment and Management of Perioperative Pain in Neurosurgical Patients. The term perioperative means before, during, and after surgery. In other words, it means preoperative, intraoperative, and postoperative surgery. Postoperative pain after neurosurgery is a common but unpleasant experience for the patients who undergo surgery. And there are several factors that affect pain in the postoperative period. Predominantly in the preoperative period, it is the age, gender, the psychological factors such as anxiety, depression, and the pre-existing pain. In the intraoperative period, it is mainly the technique of anesthesia and analgesia that is administered in the intraoperative period, and the type and the severity of nociception that the surgery entails. Whereas in the postoperative period, it is mainly the assessment methods that are employed to assess the pain, and also the quality of analgesia that is administered. However, pain results in significant consequences to the patient, which includes disturbances in the sleep, emergence and postoperative delirium, cardiorespiratory abnormalities, delayed discharge from the hospital and delayed time for ambulation, lower patient satisfaction, and in some patients, it can lead to chronic or persistent pain beyond 3 months after surgery. Now, how is pain assessed commonly in the postoperative period? There are a few scales that are used, such as numerical rating scale, the verbal rating scale, the visual analog scale, and the FACES scale. These are generally unidimensional in nature, ranging from 1 to 10 or 1 to 100, with 0 being no pain and 10 or 100 being the most severe form of pain. There are multidimensional pain scales, such as brief pain inventory or McGill pain questionnaire, which apart from assessing pain, also assess other factors such as mood, behavior, and physiological effects. They are more complex, but provide more detailed information. However, because of the time consumption and laborious effort required to implement this in perioperative period, these are not commonly used for assessing postoperative pain. Now, pain is a conscious subjective experience, and therefore, patients who undergo general anesthesia for any surgical procedure will not be able to report pain. And therefore, there is a need for objective monitors for assessing nociception in the intraoperative period. And 2 such monitors I'll be discussing in my subsequent chapters as well. Now, when it comes to pain management, opioids are the primary class of drugs that are employed for managing pain during surgery and also in some instances after the surgery. Some of these drugs include morphine, fentanyl, and remifentanil. However, they are associated with significant side effects such as nausea, vomiting, itching, sedation, respiratory depression, constipation, and urinary retention. And therefore, non-opioid drugs such as dexmedetomidine, ketamine, and regional anesthesia techniques such as nerve blocks are commonly employed to reduce opioid consumption in the perioperative period and also to reduce pain. With this background, I would like to take you through my aims of the thesis. These are to understand the current strategies of pain assessment and management, particularly in India, and identify the burden of postoperative pain in neurosurgical patients, evaluate the performance of common objective parameters vis-a-vis the conventional methods, and lastly, to compare opioids and non-opioid pain management techniques in patients undergoing brain and spine surgeries. So we'll now discuss the summary of my research questions in following chapters. There is lack of data about the pain assessment and management methods in Indian scenario, and therefore, to address this gap, we conducted a national survey among anesthesiologists to understand their preferences, practices, and perception about pain assessment and management. We also evaluated if a structured protocol for pain assessment and postoperative use of opioids for pain management can be predicted by certain hospital practice and patient characteristics. And this is what we found. Our 41% of the respondents that answered this survey informed that the structured protocol for pain assessment is present in their hospital, and only 15% of the respondents informed that they use opioids for managing postoperative pain. And we found that a structured protocol was likely to be adopted in a private setup as compared to the government setup, and the pain was less severe, and if pain scales were used. There was only one predictor for the postoperative opioid use for pain management, and it was the use of structured format for pain assessment. The second chapter deals with acute postoperative pain in Indian scenario. The studies on burden of pain after neurosurgery are sparse, especially in the developing countries. Therefore, we conducted a prospective observational study in adult patients undergoing brain surgery, where we assessed the incidence, predictors, and impact of acute postoperative pain. So every 2 out of 3 patients undergoing intracranial brain surgery had reported postoperative pain at least one time point during the first 3 days after surgery. Pain was maximal on the first postoperative day and decreased gradually over the next few days. 2 predictors were observed in our study. One is the presence of pre-existing pain, and second is pain on awakening from anesthesia after surgery in the post-anesthesia care unit. It also affected sleep and patient satisfaction. Now, intubation is a procedure that is performed to facilitate administration of general anesthesia for surgical procedures. It results in significant nociception because it's a noxious stimuli, and results in increase in the heart rate and blood pressure. Now, these are the 2 common parameters that are used to detect nociception in the intraoperative period. However, there are recently introduced monitors such as analgesia nociception index, which provide more objective assessment of intraoperative nociception. As the name suggests, analgesia nociception index quantifies the balance between analgesia and nociception. It is a scale from 0 to 100, with higher score indicating analgesia and lower score less than 50 indicating nociception. It is derived from the parasympathetic activity of the RR series of the non-invasively captured electrocardiogram. In this particular study, we compared the heart rate and the blood pressure with changes in ANI. As you can see on the y-axis, the heart rate and the mean blood pressure. On the x-axis, we have the analgesia nociception index. And there is a linear negative correlation between heart rate and blood pressure and the ANI, which indicates that ANI can be used as a tool to monitor intraoperative nociception, and it compares well with the conventional heart rate and blood pressure techniques. The 4th chapter deals with another objective parameter, that is surgical pleth index. This is a screenshot of a multi-parameter monitor showing heart rate, blood pressure, oxygen saturation, and even the adequacy of anesthesia, which is captured in the entropy. And there is one parameter that is available, that is surgical pleth index, which informs about the surgical stress in the intraoperative period. And here, the higher values, such as seen in the monitor, indicates nociception, and values less than 50 are suggestive of analgesia. And this is captured from the pulse plethysmographic waveform amplitude and heartbeat interval. In this particular study, we compared 2 commonly administered analgesic drugs, dexmedetomidine and fentanyl, and we observed that the values are well below 50. That means both the drugs were effective in reducing the stress response to surgery, and there was no difference between the 2 agents across the time points that they were measured, indicating that the effects are comparable. We conducted a pilot randomized controlled trials to inform the sample size for a larger study compare opioids and non-opioids in neurosurgical patients. In this pilot study, we had 100% protocol adherence, establishing the feasibility. We also had secondary outcome measures of postoperative pain. And again, we observed that both the drugs were effective in managing postoperative pain with the NRS, that is numerical rating scale pain values, less than or about 3 in both the groups. However, there are conflicting findings in the literature with regards to non-opioid techniques being equivalent to opioids. And therefore, to understand the overall effect, we did a systematic review and meta-analysis of randomized controlled trial to gather the overall evidence regarding these drugs for pain recovery and adverse events. We had more than 10,000 records from 3 databases, reviewed 332 articles, and finally included 6 studies in our meta-analysis. We observed that the recovery profile and adverse events were similar, and the pain scores both at 1 hour and 24 hours after surgery were similar in both the groups. Let me take a moment to explain the forest plot. This is the x-axis showing the mean difference between the 2 groups. And then we have a vertical line that is a line of null effect, and horizontal lines are indicative of the confidence interval of individual studies, with the square box indicating the point estimate. And the diamond box is a point estimate of all the studies put together. We conducted a similar meta-analysis for patients undergoing spine surgeries, comparing opioids and non-opioids, with regards to, again, postoperative pain and adverse event. Here, we observed that non-opioid drugs resulted in lower opioid consumption in the first 24 hours of surgery, and the patients who received non-opioid analgesia had required a longer time for the first analgesia administration. Adverse events of postoperative nausea and vomiting and shivering were less with non-opioid techniques. Here, you can observe on the left side, the pain score at 1 hour, there was no difference between the opioid and non-opioid group. However, the pain scores at 24 hours were 1 unit lower in the non-opioid group, which was statistically significant, suggesting that non-opioid analgesia may be better for spine surgeries. To summarize the findings of our studies, structured protocol for pain assessment needs to be implemented more vigorously. Non-opioid agents are widely used for postoperative pain management in India. This is in contrast to the Western literature, where opioids form the mainstay for managing pain in the postoperative period. And also, the structured protocol for pain assessment is more implemented in the Western population than the developing countries. Acute postoperative pain is a significant problem after brain surgery and needs to be addressed. In the 3rd chapter, we observed that ANI during tracheal intubation correlate inversely and significantly with changes in blood pressure and heart rate. Coming to the stress response to brain surgery, both fentanyl and dexmedetomidine were found to be similar, and the rescue opioid requirement and postoperative pain scores were similar with both opioid and non-opioid medicines during craniotomy. Along with this, and from the evidence from a systematic review, we observed that intraoperative non-opioid and opioids result in similar pain scores and adverse events after brain surgery, whereas for spine surgery, the current evidence from the systematic review that we conducted demonstrates superiority of non-opioid techniques over opioids for both pain relief and for side effects. Coming to the conclusion, based on our aims and findings of our research, current strategies for pain assessment and management need improvement. The burden of postoperative pain, especially in the neurosurgical patients, is huge, and this is similar to the Western population. The objective pain parameters that we studied, such as ANI and SPI, performed well with regards to assessment of intraoperative nociception. And lastly, non-opioid analgesia techniques are as effective as opioids for brain surgeries, whereas they are even better for spine surgeries based on our findings. So what are the societal implications of the research that I conducted? The incidence of pain after surgery is high, and therefore there is a need for implementing more effective strategies, including multimodal analgesia techniques in day-to-day clinical practice. The objective tools are now available for use in the intraoperative period, and their use needs to be encouraged by advocacy. Non-opioid analgesia techniques have been shown to be superior, and therefore their benefits needs to be maximized by knowledge sharing. Lastly, the findings of this research will benefit the stakeholders, that is patient partners, the clinicians, and the policymakers in making informed choices regarding assessment and management of pain in neurosurgical patients. I would like to conclude by thanking my supervisors, Professor Harry Steinbush, Professor Uma Maheshwar Rao, and Professor Satyaprabha Madam for their constant guidance and supervision, the assessment committee members for their evaluation of my thesis, colleagues, students, nurses, technicians from NIMHANS for their support in my research, the patients from whom I learn every day new things, and lastly, my family members, my parents, my daughter, and my wife for their constant support and encouragement in all my academic endeavors. Now, I now hand over the floor back to the Rector. Thank you very much.
Yes, thank you very much for this very clear and comprehensive summary of your work. Thank you. The first question will be asked by the chair of your assessment committee, and that's Professor Linden, and he's a professor of translational neurosciences at our own university.
Dear candidate, thank you very much for this very interesting presentation, and I'd like to congratulate you on this clear presentation and also your promotion team, and also in the context of this very positive international collaboration between NIMHANS and our university. Of course, I'd also like to ask you some questions, and I'd like to start by looking at chapter 5, which is about the objective of physiological indicators of nociceptive responses that you've evaluated, and you've mentioned them in your presentation again, the surgical pleth index, you've spoken about the nociception, analgesia nociception index, you mentioned glucose, you mentioned leukocyte count. Can you just reflect a little bit on these various mechanisms? I mean, these are quite different biological processes that all have something to do with nociception. Could you just explain for someone who's not, like myself, who's a psychiatrist and you're a scientist, but not from the field of anesthesiology, how these indices are linked?
Okay. Highly esteemed opponent, thank you for your question. The chapter 5 that you mentioned deals with a surgical pleth index and stress markers of surgery. The surgical pleth index, as I mentioned, evaluates on a scale of 0 to 100 the stress response to surgery. It is derived from the pulse plethysmographic waveform, and therefore can be easily derived in intraoperative period on the available monitors. The stress response from the serum that we assessed were cortisol levels, the blood glucose level, total leukocyte count, and these are some of the stress markers that are easily doable in our settings. There are other stress responses such as catecholamines, glucagon, insulin, which we could not study in our study, but the mechanism is that the tissue injury which occurs during surgery results in activation of the nociceptors, which again results in increase in the bradykinin, prostaglandins, and other hormones that are associated with nociception and pain. And therefore, this results in activation of the sympathetic nervous system, resulting in increase in cortisol levels, glucose levels in the blood.
That's very interesting. So these indices all have to do with the operative procedure, with, as you said, nociception, tissue injury, stress responses. How closely do you think are they related to what may be subclinical pain responses?
Highly esteemed opponent, the subclinical pain responses in terms of autonomic manifestation may be detected by these indices. It is not always possible to monitor these indices in other settings other than the intraoperative period, and this is a proprietary monitor available with only the G monitors. So it is that way limited in its use outside of the operating room, but can still be explored with the newer monitors that are likely to come in the market.
And if we now go for, so I think we're probably agreed that, I mean, I said these are very interesting, relevant responses, but it's a general stress system that has all sorts of components not directly related to how we perceive or might perceive pain, or how the pain-related brain areas are activated. Would there be ways of more directly accessing the pain matrix in the brain interoperatively?
There have been, highly esteemed opponent, there have been attempts to assess the difference between the response entropy and the state entropy, which measures the brain activity under anesthesia and during surgery. And the difference between these indices also have been proposed to reflect the activation of the autonomic system and the pain or intraoperative nociception. But these studies are few and are not replicated worldwide. So at the moment, objectively assessing the brain function using conventionally available tools may not appropriately reflect the changes that are occurring.
And if you were to speculate further in terms of developing this in sort of novel procedures, do you think there are ways of interoperatively accessing sort of brain neurophysiology in a useful way?
Highly esteemed opponent, I'm not sure about the answer regarding this, but I can only speculate. Probably EEG, the electroencephalogram, changes during different nociceptive stimuli. Alteration in these parameters can help in detecting nociception, provided the depth of anesthesia is monitored and found to be constant, and the changes are directly reflective of changes in the nociception that occur. So EEG has been explored as one of the intraoperative tools to detect nociception.
So, thank you. Yes, I think that's a very interesting and appropriate response. The practical implications of your work now. You've used different indices and different indicators. They're all, based on cardiovascular responses, essentially. What would you recommend at the moment? Which is the most valid indicator, you think, most in terms of reliability, in terms of validity in measuring a nociceptive response, of the indicators that you've used?
Highly esteemed opponent, thank you for your question. That's very interesting because these two monitors that I have presented, that is analgesia nociception index and surgical pleth index, have not been directly compared vis-a-vis their ability to perform better than compared to the other. All these are observation studies or comparing different analgesics and the response to these analgesics during surgery. But recently we did conduct a study comparing ANI, that is analgesia nociception index, surgical pleth index, and cardiovascular response, that is heart rate and blood pressure. And we found, we looked at two parameters. One is the response time from the baseline to change to occur, and the second one is the magnitude of the change from the baseline. And we found that ANI, which has two components, analgesia nociception index instantaneous and ANI mean. The ANI instantaneous was able to predict faster the change in the heart rate and blood pressure as compared to surgical pleth index. So the response time can be picked up faster with this monitor, but with regards to the magnitude, the response was similar in both the groups and dependent on the type of nociception or the stimulus, noxious stimulus. We compared at intubation, we compared at craniotomy and at skull pin insertion. These are the three predominant noxious stimuli in the intraoperative period in neurosurgical patients, and we could not find that one was superior to the other. So as of now, from the literature and our own experience, it appears either of the tool or both the tools are similar with regards to detecting nociception.
Thank you very much, and I hand the word back to the Pro-Rector.
Thank you, sir.
Thank you, Professor Linden. For the next question, I welcome, a member of the assessment committee who is at present in India, and is Professor Rath, and he's a professor of neuroanesthesiology and critical care at the All India Institute for Medical Sciences. Excuse me. The floor is yours.
Yeah. Dear candidate, good afternoon from here. You presented the topic very nicely in the last 15 minutes. And am I audible properly to you? I can't hear you.
You're audible, sir.
Okay, thank you. So some of the questions have already been covered, which I thought of asking you. But I will talk in terms of generalized things going through all your thesis work. To start with, let me mention that this topic probably doesn't cover the pediatric pain management. Am I correct? Any opinion on that?
Highly esteemed opponent, that's correct. In the thesis that I published, there is no literature on pediatric neurosurgical patients. So it was mainly involving adult population more than 18 years of age.
Okay. And right now you have mentioned regarding certain tools, ANI, SPI, etc. How commonly it is utilized in Indian context? And why it is not so? Means the way it is there in the literature.
Highly esteemed opponent, both the tools that I discussed are not routinely used in the clinical practice. The factors could be availability, the cost, the effect are not so evident in several studies that are conducted, And there are alternative tools such as changes in the hemodynamics that are routinely used apart from other tools such as the depth of anesthesia monitoring. And that is probably the reason why, though it is required, analgesia is not monitored, but anesthesia is monitored in the intraoperative period.
But these tools are being validated, isn't it?
Highly esteemed opponent, the tools have been validated in previous studies and are used for assessing intraoperative nociception and even postoperative, predicting postoperative pain.
Okay. And when you talk about pain management, there are pre-existing pains, there are psychological factors. That's what you have mentioned in your thesis work. So what is their influence in this perioperative neurosurgical pain management? Can you just elaborate on?
Highly esteemed opponent, your question is regarding pre-existing pain and psychological factors. So pre-existing pain, especially neurosurgical patients, is in the form of headache in patients having intracranial lesions or pathology, and pre-existing low back pain or neck pain in patients undergoing spine surgery. Now, pre-existing pain can result in some psychological changes or modulation, and these patients generally have a chronic pain more than 3 months, and therefore these psychological factors come into play, and these could be in the form of anxiety, depression, or pain catastrophizing. And these can also influence the occurrence of postoperative pain as shown by several earlier studies. However, in our observation study in chapter 2, we did not find the psychological factor, that is anxiety, though the anxiety was associated with postoperative pain on univariate analysis. On the multivariate analysis, it was not a predictor. But earlier studies have shown anxiety and pain catastrophizing to be important factors causing postoperative pain. And pre-existing pain continues to be in the postoperative pain as well. That is likely because of expectation, the attention that the patient gives to the pre-existing pain, and the expectation whether they are met or not in the postoperative period by the caregivers. That can determine the occurrence of postoperative pain in patients who already have a pre-existing or chronic pain.
Okay, thank you. And what about, you have mentioned about different assessment methods for pain management, and how commonly it is used in Indian context, and which one is the best one as per your assessment?
Highly esteemed opponent, I mentioned a few commonly used tools for assessing pain in the immediate postoperative period, and these were visual analog scale or VAS, the numerical rating scale or the NRS, and the verbal rating scale or the VRS. All the three are used in different settings. In our hospital, we generally use the numerical rating scale. It is easy to implement for the patient. That is, it is ranked by the patient from 0 to 10 and circled on a piece of paper. The visual analog scale, in contrast, is again 0 to 10 with no numbers mentioned on the scale. So the patient might find it difficult, especially if they are uneducated or have a lower level of education, and issues with regards to comprehension and understanding, especially neurosurgical patients who undergo intracranial surgery. But in our experience and the studies that I conducted, the patient feedback which was obtained informed that they are more comfortable reporting pain as a verbal rating scale, such as mild, moderate, severe, rather than asking them to score it on a piece of paper. So this was the experience that I learned with interaction with my patients. So maybe
Well,
to
I
answer
agree
your
with
question,
you.
sorry, to answer your question.
This is what we also follow in your institution. Yeah, please go ahead.
Sorry. To answer your question in the simplest way, it is the verbal rating scale which is more accepted by the patients, though as clinician we may be more comfortable using numerical rating scale and visual analog scale. Thank you very much.
Then what about patient-controlled analgesia? Means, what is your opinion on that? In Indian context, how commonly it is utilized? And that is what means in detail, there is no mention of that. How do you comment on that?
Highly esteemed opponent, I'm sorry that I did not find a significant amount of space in my PhD thesis. We did not use patient control analgesia in any of our studies. But patient control analgesia is an important option where patient gets the autonomy or control of his own pain status. So it's easier for the patient to manage his pain, and because of that, the patient may feel better and in control of the situation. The limitations of use of patient control analgesia in patients undergoing intracranial neurosurgery, I can list them as because of the cognitive impairment in immediate postoperative period, either because of the direct handling of the brain or because of the pre-existing brain pathology. It limits the use of patient control analgesia in patients undergoing intracranial surgery. And second possibility is that some patients develop neurological deficits such as hemiparesis, which may impair their bodily function to operate the patient control analgesia. But we do use patient control analgesia in few patients undergoing spine surgeries, where it is well received by the patients and by the clinicians as well. But it is not a routine practice in the Indian scenario. That is the observation that I have.
Okay, thank you. Then my question on chapter 5. So there is use of fentanyl and dexmedetomidine. How did you the dose equivalence in that study, whatever the dose you have mentioned, because one is opioid, the other one is non-opioid. So how could you suggest the dose equivalence in that study?
Highly esteemed opponent, thank you for your question. It was challenging to identify the equivalent dose for fentanyl in terms of dexmedetomidine, which is a non-opioid. There were previous studies which have compared a similar dose, which we consider in our study as well. And in our own study that we did in the chapter 5, in the figure 2, as you can see, with the equivalent dose of 1 microgram per kg of fentanyl infusion and 0.5 microgram per kg per hour dose of dexmedetomidine, the SPI values or the stress response to surgery were similar with both the techniques and were adequately maintained below 50, indicating that both the drugs were equivalent or had a similar response to their application in the intraoperative setting. So with this, probably I assume, and with previous literature, these drugs at that concentration or the dose that is used are equivalent, though bioequivalence studies are not there comparing the two doses.
Okay, so what about the role of scalp block? I mean to say regional anesthesia techniques, because opioids and non-opioids are discussed in terms of postoperative pain management, perioperative pain management. What is the role of regional scalp block?
Highly esteemed opponent, thank you for that important question. Scalp block using local anesthetic is an important component of non-opioid anesthesia technique. In our hospital, we use it routinely for all patients undergoing cranial surgeries, and it is not just restricted to patients who undergo awake craniotomies. It is a part of non-opioid analgesia or a multimodal analgesia technique that we adopt in our practice. So it is routinely used and has been proven to be beneficial in reducing the opioid requirement and postoperative pain in several studies, including several meta-analyses previously. We did use a scalp block in our patients in some of the studies.
Okay, that is in intraoperative period also you use scalp block?
We use it before, highly esteemed opponent, we administer the scalp block before the application of skull pins, so that it takes care of the response to skull pin application as well, and the effect continues in the intraoperative period till the early postoperative period, even up to 8 to 12 hours after surgery.
Okay, thank you. From my side, I think my time is over.
Yes, indeed. I think we should move on to the next opponent. Thank you very much, Professor Raad, for your contribution. And again, I welcome a guest from India. He was also a member of the assessment committee. And Professor Manikandan is a professor of neuroanesthesia at the C. Chitra Tirunal Institute for Medical Sciences, if I'm correct. The floor is yours.
Thank you, Pro-Rector. Dear candidate, it was a very wonderful presentation. I would like to start from your objectives and chapter 1. So you made an attempt to identify what are the current practices followed by the various neuroanesthesiologists across the country to effectively manage the postoperative pain. So what are the challenges which you found? What are the knowledge gaps you could identify based upon the survey? And then how you used it for your objective, for your thesis?
Highly esteemed opponent, your question is regarding chapter 1, the challenges that we observed in the conduct of the survey and the findings of our survey. This was the first national survey that was conducted in India. In fact, there were no previous studies which gathered information regarding how anesthesiologists administer analgesia and manage pain in the perioperative period. We observed differences in certain setups like academic setup versus non-academic setup, the government setup versus private setup in the way the practice of pain assessment and management is done. The challenges were observed with regards to the structured pain protocol. The absence of structured pain protocol was found predominantly in government setup, and these are the setups where there is no formal assessment in terms of NABH or accrediting agency like JCI, and that we found is a promoter of adopting structured pain protocols in the practice. So recently we have started using the NABH, which mandates the use of pain protocol as part of the assessment. Prior to this, and I have observed in the findings of our survey that many setups do not use pain assessment protocols or pain management protocols are not in place. So these are some of the challenges that I observed, and this is mainly can be addressed by increasing awareness, the benefits of monitoring pain in the post-operative period as a fifth vital sign, which is a practice or a standard of care in most countries. And then also we found that the use of post-operative opioids were significantly less. This is in contrast to the Western literature where the opioids such as codeine, oxycodone are frequently used to manage post-operative pain. And in our survey, we found that the most anesthesiologists informed that they rely predominantly on non-opioid techniques, regional blocks such as skull block or erector spinae plane block for spine surgeries. And these are, they, in their perception and their practice, they find it to be useful adjuncts rather than relying much on opioids.
So based upon this finding and your chapters, which I will be coming later on your meta-analysis, so the practice of non-opioid based anesthesiology is much prevalent in the country. Is it right? And is it beneficial, or it should be taken like a pinch of salt?
The opponent, I will present it in another way. In the chapter 2, where we evaluated the incidence of post-operative pain, none of the patients received opioids in the post-operative periods. All of them were managed with regional nerve blocks and non-opioid analgesia techniques, such as either use of dexmedetomidine, nitrous oxide in the intraoperative period, steroids, which we often undermine their utility in managing inflammation and pain, and paracetamol. The incidence was similar to that reported earlier in the Western world, where about 60%, where opioid also was used as the mainstay for managing post-operative pain as well. So I would not say that it is inferior in terms of pain relief that is offered, because the pain incidence of pain relief is similar with both the techniques, and opioids are a big problem, especially in the US. It is grown up to a big proportion as an epidemic, and they are finding it now difficult to manage opioid addiction, opioid dependence for pain relief. And therefore, I personally believe the non-opioid techniques that we adopt in our practice are good enough, but more needs to be done in incorporating multimodal techniques which act by different mechanisms to reduce pain.
Thank you, the candidate. And I would like to go to the chapter number 3 on the incidence, risk factors, and the impact of the pain, intraoperative pain on the postoperative outcomes. So based upon the literature which you have done, so what are the modifications which we can do in the practice to improve the postoperative pain management?
Highly esteemed opponent, thank you very much for your question. This has got significant societal implications, and I believe, and from our experience with this particular study, we found that pain assessment is the first step in optimizing pain management strategies. And pain assessment can be done by increasing awareness amongst all the stakeholders. Most of our patients accept pain as an accompaniment of surgery and they do not report pain well, and therefore they do not get the benefits of pain management strategies that are available. Second one is assessment is not uniformly done for all the patients all the times. Only the high-risk patients who are vulnerable to the occurrence of postoperative pain are offered better pain management strategy in terms of, example, patient-controlled analgesia. And these gaps can be addressed effectively by increasing awareness, by making pain assessment a routine practice in our post-operative period, and using multimodal analgesia techniques. It could be nerve blocks, it could be non-opioid analgesics such as dexmedetomidine, or even in the pre-operative period using neuropathic medicines such as gabapentin, and continue in the post-operative period as non-steroidal anti-inflammatory drugs and paracetamol.
So one more question related to that. You have done few objective assessment of pain. Do you think that has got a place in post-operative assessment of pain?
Esteemed opponent, the ANI and SPI have predominantly been studied in the intraoperative care settings. To my knowledge, I am not aware if these two assessment tools have been used in the post-operative period. One of the possible reasons which I think could be the effect of certain drugs which affect these indices, such as those drugs which affect the autonomic nervous system function can affect, and it is not a uniform period. Several factors come into play. Probably these are the reasons why these tools are not studied outside of the operating room and are largely restricted to the intraoperative room. And the second and most important reason is that after the influence of anesthesia wears off, that is in the post-operative period, patient can as well report the pain. And pain is, as understood, is a subjective experience and is best expressed by the patient himself rather than monitoring it using certain tools which have certain limitations. Because the patient cannot report pain in the intraoperative period under general anesthesia, we have to use these adjuncts to inform us about adequacy of analgesia and the degree of nociception.
One more final question I would like to ask you. You have done various research in different areas for related to preoperative survey, preoperative assessment, intraoperative management, as well as postoperative meta-analysis. So throughout your this research period, what were the limitations of your study? How it has to be processed in the future direction? What is the future of direction of your research?
Highly esteemed opponent, thank you for your question. The limitations that I observed during this research work pertains mainly to those individual studies that I mentioned in the chapters. In the chapter 1, we observed that the pain assessment is not uniformly done, and we need to see if including pain assessment as a routine practice reduces the occurrence of pain in our population. So that is the gap that we can try to address. The second one is, despite using several non-opioid techniques, including regional skull block, the post-operative pain incidence is high. And therefore, we need to explore other tools, other drugs, other modalities for assessing pain. In our systematic review and pilot randomized controlled trials, we observed non-opioid techniques to be equivalent or even slightly better in patients undergoing spine surgery, and these needs to be strengthened, incorporated in our day-to-day practice more widely, so that we can give this benefit to our patients in the post-operative period.
Thank you, candidate. Thank you, Pro-Rector, for the opportunity. Thank you.
And thank you for asking these interesting questions. I now turn to another member of the assessment committee, and that's Dr. Vossen, and she's a neuroanesthesiologist at our Department of Anesthesiology in Maastricht University.
Thank you very much. Congratulations, dear candidate. Congratulations for your promotion team. And my question is, what took you so long to put together a thesis when you already published so many papers? So, especially on this important subject, because postoperative pain is a major concern, and I think there's a lot of research going into craniotomy. So, thank you for addressing this problem in this thesis. But you state that it's very important to consider the non-opioid options, and I do agree to some extent. But could you please elaborate on the question, could you really do without opioids in the postoperative setting?
Highly esteemed opponent, thank you very much for your comment and your question. On the surface, promoting non-opioid analgesia as an alternative, as a sole alternative to opioids looks provocative, looks challenging to the well-established practice of opioids being the mainstay of pain relief medications in the intraoperative period as well as the postoperative period. But there is increasing amount of evidence that is now published which support that non-opioid analgesia may not be as a single drug or a single technique, but combining that with several other techniques which act by multiple mechanisms, addressing different pain from different ways, is equivalent, at least, if not better than opioids. And therefore, it is no surprise for me, at least in my research, that from the meta-analysis that I observed, non-opioids fare good as compared to the opioids. But your question regarding whether non-opioids will replace opioids in the near future, well, it is unlikely, not because they are not effective, but that has been shown and proven in several studies, but because the mindset that most anesthesiologists, most surgeons, neurosurgeons especially, are reluctant to move from the well-established practice of using opioids. The first drug that comes to the mind when there is a pain reported in postoperative patients or the intraoperative period is the opioid. So that will take some time. More evidence needs to be gathered in different settings. More robust evidence needs to be shown to the practitioners to make this practice change. So at the moment, the short answer is no, unlikely.
Yes, because in the meta-analysis there were 6 RCTs, but a couple of them had remifentanil in the studies, and of course remifentanil is known for hyperalgesia. So I wonder, could you elaborate on how this affects the outcomes of your meta-analysis?
Thank you very much, highly esteemed opponent. Let me first confess that I have no experience with remifentanil. It is not available in India, and that is one of the difference why the analgesic that we administer and the evidence that we generate is slightly different from the Western world, where remifentanil is the primary drug that is used for managing pain in the intraoperative period. And as we all know, remifentanil is the ultra short-acting drug, which the effect wears off immediately on stopping of the infusion, and therefore these patients are likely to develop pain as soon as they wake up after surgery. And as you rightly mentioned, it has got some hyperalgesia component as well, and therefore personally, it is likely to be introduced in India in the near future, but we are more comfortable using alternative, which I mentioned, that is dexmedetomidine, which performs well, and the effect outlasts its duration of action and the infusion time period. So it can be used where the intensity of the stimulus is very brief and very intense. Remifentanil is a good drug, but I'm not sure, because I have not used it, whether it is likely to be different otherwise.
But could it have influenced your outcome? Because we use remifentanil, but then we, like 45 minutes before ending the surgery, we give a little bit of opioids and of course paracetamol and a scalp block as well. But could this have affected the outcomes in your study, in the meta-analysis?
Esteemed opponent, that is a good observation. 3 of the studies that we included in the meta-analysis had remifentanil as the intraoperative opioid, and the comparative group was predominantly dexmedetomidine. And so the 2 drugs are very differently, and therefore remifentanil use could have influenced the findings of our study. There was no mention about the use of probably morphine as a transitional analgesia in those studies, so we do not know for sure, because the access that was available for the primary studies was limited, and as you rightly said, remifentanil could be responsible for finding of the different observation that we had from the meta-analysis.
So it's probably too early to draw any conclusions.
That's right.
Thank you. Another question, it pertains to chapter, let me see, chapter 4, about the ANI in the induction stage. It was a very nice research and looking at the data points in table 2 about the mean blood pressure and the heart rate. I was surprised about how much they would rise after 2 or 3 minutes after laryngoscopy. And I was wondering if I would induce a patient for a clipping of an aneurysm, I would be quite concerned with these values. How would you elaborate on this?
Esteemed opponent, thank you for your question. As rightly observed by you in the table 2, the blood pressure rises were significant at different time points. Predominantly, the highest change was at 2 to 3 minutes as compared to other time points. And it is a concern, especially in patients undergoing aneurysm clipping surgeries. But this study population was patients who were undergoing tumor surgeries. And this was observed despite what we consider as adequate analgesia at induction. The fentanyl 2 microgram per kg is what we administer, along with a sympathoablative drug like lignocaine, preservative-free lignocaine, and appropriate dose of anesthetic induction agent. And we perform the endotracheal intubation only when the minimum alveolar concentration of inhalation agent is at 1 mAq or above. So despite these precautions that we generally take in terms of adequacy of analgesia and anesthesia, we observe these changes. And therefore, it is a concern when, especially like the example that you gave in patients managed for aneurysm surgeries.
But would you change your anesthesia regimens? I can imagine some anesthetics have a more are more favorable when seeing the when looking at the what was it called, the HF-LF ratio.
Esteemed opponent, thank you for your question. So your question pertained to what changes I would make in terms of providing analgesia based on the changes in the LF-HF ratio. So LF-HF ratio changes is predominantly reflective of autonomic response to a nociceptive stimulus. One of the factors that we can do is probably with the availability of remifentanil, which is a short-acting drug, so that the effect does not outlast the period that is required. The intubation in this chapter, which you mentioned, is a short duration of procedure. The stimulus is very intense, but very short lasting, maybe 30 seconds, not more than 30 seconds. And therefore, this drug, such as remifentanil, will be helpful because, again, the effect is catered to the period that is required. What we find is that if you use a larger dose of available drug like fentanyl in 3 mics or 4 mics to ablate the response to intubation, subsequently there is a period of null effect. There is no stimulus to the patient till the patient is put on a pin. And that period somewhere lasts from 20 minutes to 40 minutes and the patients develop hypotension. So we do not want that consequence also. So we have to make a fine balance between providing optimal relief from nociceptive stimulus and also avoiding hypotension, which is again detrimental to the pathological brain that we operate upon. So at the moment, I am looking forward for remifentanil as one of the ways to adjust the analgesia during that particular nociceptive period.
And perhaps propofol.
Propofol, yes, madam. Thank you.
Thank you, Dr. Vossen. I now turn to the secretary of today's degree committee, and that is Dr. Berenschot. He is an associate professor in the Department of Ophthalmology at the Medical Center here in Maastricht.
Dear Mr. Candidate, first I like to congratulate you with this very impressive work. As we have heard, it's also relevant from a societal point of view, and a lot of discussion is ongoing, so that means that it's really relevant, this research. I want to continue a little bit of discussion which you have with Professor Raad on Chapter 3 and some of the observations there, and that's particular on the biomarkers. So if you look at this post-operative pain, then pre-operative pain, that seems to be a good biomarker. So my maybe silly question would be, if you relieve the pre-operative pain in a certain way, would that also be then beneficial for the post-operative pain? And why and how to accomplish this?
Highly esteemed opponent, if I have understood your question correctly, is addressing pre-operative pain likely to be beneficial in post-operative pain management as well? Yeah. Thank you. That's absolutely correct. Pre-operative pain has been consistently shown to affect occurrence of post-operative pain, and pre-operative pain can be assessed in multiple ways, including non-pharmacological ways, such as positive feedback to the patient, training them with cognitive behavioral therapies and making them more acceptive and encouraging more ambulation. For example, in a patient undergoing spine surgery, a non-ambulation is a factor which results in pre-existing pain and can also result in fear component, and that is a vicious cycle. So addressing pre-operative pain, pre-existing pain is important. It also is a component of prehabilitation, what we include in our ERAS protocol nowadays. So it is an important component that needs to be addressed before the patient undergoes surgery.
So this is implemented already. And if you really want to prove this, then I guess a kind of trial would be the optimal way to do so. So counseling patients about their pain and the others not. Has this been done, or are you planning to?
Highly esteemed opponent, currently we do not counsel pain, at least in our setup, and I think that is a point well taken. We need to do it as a routine practice in all the patients. We do it on a case-by-case basis. If the patient reports pain, most of the patients do not report pain unless asked by themselves. They consider pre-existing pain as a pathological disease which gets cured, in their words, after surgery. So they do not often express it in our pre-anesthesia clinic evaluations. They take it as a part of the pathology, such as headache for a brain tumor patient, or spinal pain, back pain and leg pain in a spinal pathology patient. So counseling is not routinely done in our setup in the pre-operative period for patients who have pre-existing pain. I think that's a good idea for me to take back and discuss the feasibility of implementing in my setup. I think it's doable, and definitely patients will benefit. Thank you for that suggestion.
Yeah, maybe to further a little bit. So is a particular pain, so you mentioned headache, and now you mentioned spinal pain. Is a particular type of pain which is more predictive for postoperative pain?
Highly esteemed opponent, the headache pain that I mentioned is for patients with intracranial pathology, which we see in our setup, and similarly for spinal pain is mainly for the patients who suffer low back pain, who come for a surgery like microvascular decompression or laminectomy procedure or a stabilization procedure. So these are two different pathologies. The cranial pain is slightly different. The headache is predominantly because of the stretching of the membrane on the brain called dura mater, which is occurring because of increase in the intracranial pressure, whereas in the spinal pain, it is predominantly because of impingement of the nerve or osteoporosis or some other structural pathology in the muscle or the bone or the nerve. So these are slightly different and needs to be addressed slightly differently.
Yeah, the reason I ask is this because I had some discussions with your promoter, which is online, on the use of yoga. So I wonder, could yoga be an option to to look at pain and how to address this, and would there be different kind of yogas for the different pain you observe?
Highly esteemed opponent, that is a very relevant question for our setup. We do have a yoga unit in our hospital, and if I remember, one of my neurosurgery colleague is currently evaluating the effect of yoga versus the need for surgery, the waiting time and performance of yoga for Hirayama disease, that is a pathology which causes numbness in the hands and weakness and pain as well. So preliminary observation from that particular study is that yoga does help. It also reduces the need for surgery for pain and for numbness. So it looks promising, but it's too early to say unless it is replicated and convincingly demonstrated in multiple studies.
But yeah, I just am curious. What kind of yoga are we discussing now? Can you elaborate a little bit more on that?
Esteemed opponent, yoga is mainly control of breath and alignment of that along with some form of asanas, what is called as a physical exercises. They are, to put it simply in layman's term, the physical activity or physiotherapy that we initiate as a part of prehabilitation in patients with spine pathology involves mainly the physical part. There is no the mindfulness or the cognitive component that is added to this physical activity, whereas in yoga, it aligns the breath, the asanas or the performance of certain physical activities along with some psychological impact. So these put together are likely to benefit more than physical exercise alone. So,
And how long before the actual surgery should you start with such yoga exercises or training or?
highly esteemed opponent. In the particular study that I mentioned, where my colleague is involved, they did 6 weeks of yoga. The first yoga was for 1 hour, implemented during the hospital visit, and in the subsequently, it was followed up online by the person who is involved in care of the patient, and it was regularly observed that it is complied with during the 6 weeks period. Sorry.
Well, thank you. I'll have many more questions, but let's leave it for here.
Time is up. Time is up. Hora est has been called out, which means, Sriganesh Kamath, that the time appointed for the defense of your thesis has now passed, and that implies that the committee here will withdraw and discuss the quality of your defense and of your thesis. And I would like to ask you and company here and online to await the results of these deliberations here, and we'll return.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Make the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
to
Yeah,
hospital?
no, it's there, but even in the first week,
Oh.
when they really suffer, they just
Okay,
don't.
no, I don't know whether you should call it a suffer, because if they really...
Please rise. Please be seated.
Sriganesh Kamath. The degree committee here present has assessed the quality of your thesis and the way you just defended that thesis. In view of its positive verdict and taking into account, of course, your previous qualifications, the degree committee has decided to grant you the degree of doctor. And this implies that Professor Steinbusch, your supervisor, is authorized to confer upon you this academic distinction in accordance with Dutch university custom. Please, supervisor, take the floor.
Please all rise.
Hello. Dear Mr. Kamath, do you promise to work in accordance with the principles of scientific integrity at all times? To be careful, to be honest, to be transparent, to be independent, and to be responsible?
Yes, I do.
Thank you. By the authority vested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Sriganesh Kamath, the degree of doctor, and grant you all rights attached by customs and law. As evidence of this, I now present you with the degree certificate signed by the rector, by the secretary, and all the other members of the committee here available. And of course, affixed with the official seal of our university.
Thank you.
Take off my glasses. Yeah. I know, a little bit.
Thank you.
Please be seated.
Now I put on my glasses again. I'm sorry. So, Dr. Kamath, how does that feel?
Relieved.
Relieved. That's the right answer. Relieved. It's finally over. Yes. And I mentioned already to you, and we discussed that yesterday. I would do what you called a short laudatio. You said don't make it 7 minutes, make it shorter. I would do a little bit historical perspective, and I said when do we started with this project, and when do we start with the project with Professor Rao. So we really started in 2011 when I was for the first time at NIMHANS, and we started the collaboration. And you came in the picture in 2019. It was at that time, I wasn't in the picture because I think we should be fair about this. It was also in the acknowledgement, and it was basically by Professor Kramer who was there. He disappeared, and I took over, and 2 years ago, we really started a large number of discussion. And first of all, we started the discussion, what should be in the thesis, and what is still missing in the thesis. And we added 1 or 2 additional chapters, and we had a lot of conversations, always by Zoom. We were in the Corona time, till I was in NIMHANS about 2 months ago or 1 month ago, and we really did the full rehearsals. And I always mentioned to you one question which I thought was important. And you mentioned to me, I can speak a lot. I have 250 papers about anesthesiology. I said, no, that's not the idea. We go for 7 chapters. So can you choose 7 papers out of your 250 papers? And always I push a little bit. I push a little bit with you the 2 questions. And in the beginning I said, it's maybe a little rude if I ask you this, but can you tell me why is this important? is your work important? Is it just for yourself, for your family, or for your friends? And I said, the first question which you have to address always in mind, why is it important? For whom is it important? And you mentioned quite often my patients in India. And I ask you, put you also a little bit in that respect, I always ask you, why are patients in India different from patients in the Netherlands? What makes the difference? Is it a race issue? Is it a gender issue? Is it what kind of difference? And you really took that question seriously and concluded this, that you really moved forward to that. And also the discussions today went very well. I wish you a lot of success, and I know that you're going to proceed in Nimhans, and I think we will hear more from you, because basically, as I would like to see you personally, I would like to see you as now as our ambassador at Nimhans. You are the one who's going to train our students in anesthesiology who might come maybe to Nimhans, and I think you're very well adapted to that. Nimhans is a big institute. For those of you who haven't been there before, I mentioned it also to Professor Nanne de Vries. They do 480,000 patients per year, which is quite a different number than we have here. And you can see, you can train them and show them a whole variety of different patients over there in a very short time. In my congratulations, I also, of course, would like to mention, which you also included in your last slide, your family, who is now live, available. We look over there. Okay. Somewhere there, over there is the live stream. So we like to mention your wife, Rashana, and your daughter, Chandra. And I would like to welcome them, and I would like to congratulate them with their father, of course, too. I also like the promotion team, Professor Rao. We know each other for quite some time. Thank you for coming. Thank you to took the long trip today and yesterday to come over here and join this meeting. I had expected, but she's not here, that Professor Satya Prada would be here as well. But I think we lost her somewhere online between India and the Netherlands. I also would like to thank the members of the Corona. Yes, it's always important that we have 5 members here at least. I would say thank you that joining, also our colleagues from India, Professor Rade, Professor Manikandar. Thank you that you joined today, that you have maybe the first time that you did a Zoom meeting, a Zoom PhD thesis with Maastricht University. It takes 9 minutes to ask questions, but it takes more time to prepare the questions, I would say. And I would like to thank you for your time. And of course, Professor, I can see it here, Professor Satya Prada is again at the ICU. To mention that, she couldn't join because her husband is seriously ill, and that's the point that she couldn't join, and I think she is back with her husband at the ICU. Is that correct, Professor Satya Prada? Can you hear us? I just mentioned to you that I also thank you as promoter that you have joined the thesis defense together with Professor Rao.
Thank you, sir.
Okay.
Thank you, sir.
Okay. In the future, let's talk also a little bit forward. I'm looking forward, together with Professor Satya Prada, who might be here in March, something like that, 2024, in which I will do my last Nimhans defense together with Mr. John, who likes then to join here in our theses. And by that, I would like to conclude. I think also the pro-rector that he took the time this morning. It's his free time, so I know also about this, that he was here available as well. And I would like to say hello to all our Nimhans friends who are looking at the moment. I know there are quite a lot who like to attend, and I would like to say greetings to Nimhans, and I hope some of the students who are now watching at the moment, that we would like to welcome them in the future here as well in Maastricht. And by that, I would like to conclude and give back the word to the pro-rector.
Thank you, Professor Steinbusch. Also on behalf of the academic community here in Maastricht, Dr. Kamath, I'd like to congratulate you, your family, your friends, and your colleagues, and anybody who is online witnessing this ceremony. and of course also your supervisors. I think it was an impressive thesis and also an impressive defense. I really enjoyed it. I already said something about the presentation, which I found very clear. But also I think somebody with a CV like yours, with so many papers, you know, you have a real impressive academic record already, which we don't see often in PhD candidates. So you've been really advancing well. And that also showed in, I think, the way you defended, because it was really, you know, for me, a relaxed, comfortable situation here. And sometimes that's different, actually. I would also like to congratulate the School for Mental Health and Neurosciences at Maastricht University, together with NIMHANS, which is the National Institute for Mental Health and Neurosciences. There's also, let's say, some beautiful name sharing there. It's been a long-standing cooperation between the two institutes. It's been productive as you have been. Also, this cooperation has been very productive, and I think it also has a future. And that is very important, both for Maastricht University and I hope also for the National Institute over there in Bangalore. I would like, and of course you already mowed away the grass, as we say in Dutch, but I'd like to thank the opponents today and the members of the degree committee, because they've been investing time and energy, and they have been really productive also in asking you the proper questions. Somebody talked about relief. You talked about relief. The way I saw you today, I think relief, well, I couldn't see any nerves, or so I think you stood well, and you deserve the title you just obtained. Now, with that, I'd like to conclude this session, which means that the audience will be switched off. We will stay here, and also the opponents, and I hope Professor Satya Baba will stay on, and we will take a photograph here so that you will have a remembrance of this day when you get back to normal life. And thereby, I would like to close this session.